The following is a presentation of the Healthcare Facilities Network.
Hello, and welcome to the Healthcare Facilities Network. I am Peter Martin, the president of Goslin Martin Associates. I need my glasses. It's funny that my eyes are just getting progressively worse, which I do not like. But anyways, that's the cost of getting old, I guess, which actually ties into our discussion, right, Steve? So let me first introduce my guest, Dr. Stephen Call from Washington State University. As you may know, he's the assistant professor in the School of Design and Construction at Washington State University. He also is the consultant and founder of Built Environment Resources. He also has a background in facilities management and healthcare facilities management. So when you hear him speak, he comes from both sides of the spectrum. He's been in the field and in the trenches, and he's done a lot of research, and he's done a lot of research on a lot of interesting areas that are relevant to healthcare facilities management today. And that's why I asked him to appear. So welcome, Steve. Thanks for joining.
Yeah, thanks for the invitation.
Let me ask, can we start with the your PhD in construction management? What is that program?
So it was out of Arizona State University. I was actually, I kind of got started into the world of academia when I was invited to be an adjunct professor at Brigham Young University in their facilities management program. So that was the same program that I graduated from, almost 20 years ago, to teach a healthcare facility engineering course, interestingly enough. So I thought, hey, I'd be curious to maybe get in this world. Maybe my plan originally was just to maybe look at an early retirement, slowly get chip away at a PhD. There really isn't a PhD in facilities management or facility management. You can get a PhD in the built environment or a PhD in construction management are kind of the two primary paths. And so just networking around and chatting with folks, ran into Ken Sullivan, who was leading that program at ASU, and he did a lot of his research was in facility management. So there was a really strong collaborative connection there. That's how I came into it. So all my research, interestingly enough, with the PhD, you can call it what you want, but you really have tremendous flexibility in choosing your dissertation topic and your research area. So my research was dedicated to healthcare facility management, even though the PhD is in construction management.
Okay, excellent. So you've done a lot of research, and kind of that's what I'd like to touch on with you today. We'd like to talk a little bit about salaries. I'd like to talk a little bit about some research that you've just released relative to infrastructure and recapitalization cost savings that you've done. I know, this summer and probably before the summer, you've been working on some benchmarking reporting with IFMA or sponsored by IFMA. And then I'd like to talk to you a little bit about, what's next. So you get your hands in a lot of areas. Let me just ask first, before any particular salary info, Steve, we're in a unique time, 2023. Have you seen any, and as you research these things, have you seen any type of market fluctuations or anything relative to the market of healthcare facilities management that has surprised you or that's made you stop and think a little bit more?
Yeah, so I'll say maybe it was a year and a half ago or so, there was a very large research project sponsored by the International Facility Management Association, looking at salaries, facility management salaries across the globe. So geographically spread, but also we looked at the data specific to different industries. So the primary industries hiring facility managers are really government entities, education, healthcare, and then you'll just kind of general corporate type environment. And what I found really interesting is as we looked at, as we separated out those that salary data, and we looked at different levels too, right? We had a level 1 through a level 5. Level 5 being kind of the executive level, senior level role, level 1 more of an entry level. So we kind of broke that by job levels. So entry, mid, senior level is really what that categorized as. When we looked at those different levels, healthcare, interestingly enough, was paying significantly below market compared to other industries. And now that was just specific to entry level and mid level. Once you got to a senior level role within healthcare, it was equal compared to other industries. So I think what's happening a lot of times is healthcare organizations, the HR teams out there comparing salaries to other healthcare organizations.
Yeah.
And so they're saying, well, hey, a lot of times the director is saying we're having a hard time finding people, we're not paying competitively, and they're saying, well, sorry, our banding seems to be matching other healthcare organizations, but the real competitor isn't necessarily the hospital down the road. It's other organizations that are trying to recruit for facility managers. So that's when you say, what do I find interesting? I think that's a really important thing that the facility leaders can now be armed with, to say, well, time out. I get that you're comparing yourself to other hospitals, but we really should be comparing ourselves to other industries as well, because that's who we're competing against. So this issue of struggling to find entry level talent it's a huge barrier because of the salary issue. And now how does that get resolved? Well, that's something hopefully we can all start figuring out. But I think we've identified a really key roadblock that we all need to start working towards resolving.
That what is it a significant difference between healthcare and those other areas? Is it enough to that maybe healthcare can compensate because it offers more things than maybe another industry does, or is that differential just too large?
Yeah, so if you look at the actual, is there statistical significance?
Yeah.
And the answer is yes.
Okay.
And so across, on average, I will say it's about $10,000. So on average, healthcare pays about $10,000 less per year than other industries for entry level roles. And now one could argue, hey, well, healthcare, you could, sell the case that this is a different place where you're more mission driven, right? You can kind of appeal to those things. But again, is it worth a significant amount of money? And that's the question. I would argue that most people, some people will, right? Some people say, yes, I'm happy to work in healthcare, and others won't. But again, we just need to recognize that there's a significant barrier there, and we need to do everything we can to overcome those barriers. The other thing I'll say as well, there's no secret. I've been in a entry level, mid level, and senior level role within healthcare facilities management, and healthcare is a very difficult job. I've been in healthcare and I've been in other industries, and I would frankly, healthcare is more difficult. It really is a challenging environment. It's a 24/7 operation. There's a lot of pressure involved with regulations and continuity, business continuity, and those sort of things. So yeah, it's so not only is it a more difficult, more stressful job, but we're paying people less to do it.
Yeah. As you were talking, I was just thinking, and I agree wholeheartedly with you. I had done a, excuse me, on the Healthcare Facilities Network. I interviewed this summer. I did 2 interviews with an intern in California. He's a gentleman by the name of Aiden Cornell. He's going to be a junior in engineering.
Yeah.
And he was hired by Robert Hacker to work in a hospital, and he knew nothing. We talked a little bit about what did you know prior to coming into healthcare. Also importantly, do your professors, do you hear about this career in your, while you're in college? Are you aware of it? Do your friends know about it? And he was like, I had no idea. And the reason he found his way in is because his mother works at the hospital, talked to Robert and said, hey, can my son be an intern for you? Yeah. And it kind of worked that way. You're in academia. Obviously, you're a little bit different because healthcare facilities management, but students, college students, what's their mindset relative to careers? Are they aware of this, or is it, you just talked about the pace, Steve, and that's you're on call all the time. The younger generation, what's their visibility to healthcare, and how are they going to change it? New generation coming up.
Yeah, there's a couple.
Sorry.
Yeah, no, there are a couple insights there. I will say, first of all, there are very few dedicated academic programs for facility management. There are engineering programs, there's construction management programs, there's architecture programs, but there's very, very few that are dedicated to facility management. So I don't at Washington State, I teach architecture, construction management, construction engineering students. Another issue with that, when you talk about construction management, I talked about that $10,000 difference. Throw in construction management, add $20,000 to $30,000 difference. There's a huge difference between construction management and facility management when it comes entry level, right? Yeah. It evens out when you start going up, as the position responsibility increases. So that's an even more difficult issue to try to sell a 22-year-old student that you can make 90,000 or 65,000. So that's a hard sell. I think the question of the other fact I've mentioned before in some of our previous conversations is the healthcare industry simply isn't hiring. So even if you had all these facility management graduates that are interested in healthcare and are well prepared and are aware of the industry, healthcare is simply not. I mean, very rarely do they hire a new college graduate. All other industries are gobbling those students up at pretty significant rates, but healthcare's the trend is to not hire new college graduates for a number of reasons. I will say primarily the reason I get is there's a reluctance, besides the pay, to take the pay out of the question, but there's a reluctance because the traditional succession model has been we grow through the trades. We've got a gentleman's been here 10, 15 years as an electrician. We promote him into an entry-level manager role. So you're talking about, you've got candidate A who has 15 years of experience and candidate B who has, an internship. And there's a concern about the perception within the workforce about bringing someone in with no experience over someone who's been there, even though there's argument to say who could be more successful in the long run. So that equity issue, it seems to really bring a lot of heartburn to hiring managers.
I have to imagine too that going forward, everybody's so busy that even if you bring in that person who maybe has that no experience, are you setting them up to fail without the infrastructure in place to support that? If you're looking at staff levels that are decreasing, more responsibility, it's the right thing to do. You may know it's the right thing to do intuitively, yet you can't do it because this person's going to fail if I bring you in.
Yeah, well, that's an interesting, again, there's a perception there that a college graduate the runway it's going to take them to take off is so much longer than someone who's been in the hospital for a decade. Yeah. What the research is showing is that's actually not true at all. So someone with 15 years of experience that's promoted into an entry-level facility manager role in a hospital is being promoted to that next level of management just as fast as someone who came in from college. Now, specific to construction, facility, or engineering, they're kind of being promoted at the same rate. So what the assumption there is saying, well, they're about equally prepared. Then it goes back to, okay, what are the competencies that it takes to be a successful manager? Instead of saying it's going to take some time. So if you look at those competencies, there's a mixture of soft skills, financial, business related skills, also technical plant skills, and each one of those candidates typically has some gaps. And so it's never those internal training programs. Those internal training programs are really important, and so that would be the key. I would say is you're preparing everyone to fail if you don't have some infrastructure or some framework around how are we training our people to make sure that we're addressing those individual gaps with those different candidates.
Yeah, I mean, there are no perfect candidates out there today. Yeah. It's just doesn't work that way. This is Peter Martin. If you or your organization is interested in advertising or partnering with the Healthcare Facilities Network, including sponsoring content, then please email me using the barcode in the lower right of your screen. From the trades level to the vice president level, from planning, design, construction, project management, compliance, safety, and security, the Healthcare Facilities Network reaches FM people where FN
Yes,
people
when
are. You're doing a survey, Steve, I guess this is more process related. How long does it take you to work it through, compile it, to make sure that you're being comprehensive and
Sure.
and your data, and you've worked like how long does that process take?
Well, the time consuming process is accumulating the data. So like with workforce information, um, it just depends on how developing a good survey that's capturing the right information. You try to think of the end when you start at the beginning of these. A lot of times it's survey or data collection, because you're trying to say, what data do I want to collect that I can then analyze statistically to provide some reliable findings. So it usually takes several months to get enough information to have a large enough sample size to be considered statistically valid. There's other research that I do a lot of times with, we may touch on this here in a bit, but on like hospital cost information and those sort of things. A lot of that's public, so I don't have to go out and do all these surveys. I can pull hundreds of hospital financial information and data points to then start analyzing the data. So that and then it goes into data analysis and just trying to figure out, comparing different things or running different tests and trying to find connections to the data. So and then once that's done, you write a paper, you turn it into a peer-reviewed journal. That could take almost a year before you submit the paper to when it's all done. So on average, it takes about a year and a half to 2 years from when you start down a journey to when you actually have a paper to say I'm done, right? Move on to the next step.
Yeah, we get next. Relative to a salary survey or the salary work you have done, given today's circumstances relative to inflation, the job market, everything we're experiencing when we go to the gas pump or the grocery store, and the cost of living, how relevant are salary? Not relevant, they're obviously relevant, but how reliable is a salary survey that's done, say, a year ago, 2 years ago, relative to kind of that market today? Does that have any impact, or what? And if it does, what is the impact?
Yeah, I'm sure, with the high rate of inflation that we've all been dealing with, I'm sure that's impacted.
Yeah.
Now, what I would say is, so if you're saying, hey, what should my salary band be today, then obviously you want to have the most current information as possible.
Yeah.
A lot of times, what I do research for is to say, what are the big challenges? What are some misconceptions that we can start tackling? And so, for example, this idea of healthcare pays significantly less than other industries. That's kind of a big. I mean, that's really not related to a couple $1,000 variance in inflation. So that's what I would say. Those are usually the points that I focus on when I talk about my research. Is what are the big takeaways? What are the key findings where we can really start shifting our focus to resolve some of these challenges? So yeah, I'm sure inflation has some impact a little bit.
Yep.
I don't think it, but I think everybody's dealing with that. So
Right.
If healthcare was paying below market, 2 years ago, they're still probably paying below market, in the future.
Yeah. Yes. And you had mentioned, so relative to the salaries, healthcare catches up at the manager and or director level. Where does healthcare equalize with those others?
Yeah, and as you know, every system has different titles. So I might be a director, a senior vice president, whatever. So a director might be a senior level at one place and a VP at a different place. But I just say I just categorize them entry level, mid level, senior level.
Okay. And
so entry level, there is a statistically significant difference.
Is entry for you 0 to 10, 0 to 8? What is that? How do you define that?
So typically the role would be more like a supervisor, like a foreman, a kind of a professional type role. Many places are called manager, right? It's just that first step into a manager role, assistant manager.
Okay.
That title can vary a little bit. And again, I don't like to go by years because somebody from college could assume that role at 0 years of experience, or someone within the trade may have 10 to 20 years of experience when
Yeah.
they move in. But usually it's zero as far as management experience. It's usually 0 to 5 is that type role. Mid-level is more like a 5 to 15, and then senior levels 15 beyond. And so that's usually where you're seeing it. In the mid-level, there is a difference, but it's not statistically significant. So, and then senior level, it's completely even with the rest of the industry.
Okay. Okay. Interesting. Anything else before we move off of salary, Steve? Anything we didn't cover, or anything, you know, that's on your mind relative to salary?
Well, the last thing I'll say about this issue is the big issue is how do we attract and retain a competent workforce in healthcare facility management, because we have such a huge wave of retirements that have happened and are continuing to happen, and so are really at a crisis point, to be honest.
Yeah.
And this is just one thing that we can't just ignore, is what are the barriers that are preventing folks from entering and staying in the workforce. Pay is a huge issue. The reluctance to hire folks outside of healthcare or outside of the trade workforce is another issue. And so, you know, we can't just keep ignoring those issues. We have to kind of face them head on. So that's my goal in all this, is kind of talking about it, explaining the pros and cons of different approaches, and hopefully we can improve this attrition challenge we're all dealing with.
And one way or the other, whether it's done willingly or just kind of pulled along, people from outside of the industry are going to have to be hired. I mean, there simply won't be enough people to sustain what we have.
Yeah. And at that point, unfortunately, we're going to have, I think, a skills gap, and we're going to lose a lot of people that understand healthcare and understand the nuances, and then we're just going to have to bring people in, either externally or really start focusing on, you know, these partnerships with some of these service providers.
That leads me. So you posted an article, it was in late June or July, right? You did a study on infrastructure recapitalization cost savings from facility operations in Washington state hospitals. So I'd like to jump to that. And I'd actually, one of the things you wrote in there, and it kind of goes along the lines with what you've just mentioned, and that's why I want to get to it. I'm kind of skipping ahead what your finding was, but I read this line in here, which I thought was really interesting. You write, and it was on page 2, there's growing concern that without billions of additional dollars being invested in facility infrastructure, the majority of hospitals in North America may exceed their useful life by 2031. I thought that was, that line really did stand out to me. The majority of hospitals. So that's significant, no?
Yeah, I think so. And I think so. Again, I'm trying to paint the picture of why this research is important.
Yeah.
And if I'm not mistaken, I think that reference was from the American Hospital Association. So
yeah, you footnoted 10 to 12. So yeah, you start off.
Yeah, so these are statistics that are, even the AHA are saying, hey, we've got a problem. So it's not Steve Call inventing problems. We've got these huge problems.
Headline: Steve Call, hospital.
Right.
Gotcha.
We've got, everybody's aware of the problem, but how do we come up with some solutions? And that's always my focus on my research, saying how can I help? How can I help with this problem of aging infrastructure? Everybody feels it. Every healthcare leader you talk to says, and they recognize it. We've got aging infrastructure with limited amount of funding to actually address it. And so how do we help with this?
And I think one of the things, and I'd like you to kind of talk about your findings here, but one of the ways where I think healthcare facilities management works against itself or to its detriment is that the folks, the people in it are so accustomed to just keeping things going. They keep it working past their useful life, and they keep it working past when they should have, and they go so far, they're able to cobble it together to keep it moving forward. And then it bites you, because ultimately it fails.
Yeah, if you look to the evolution of the facility management profession, from being completely operational focused and just kind of we keep things running
Yeah.
to where we really should be going, which is being
Yeah.
able to explain the value in financial terms to what we're doing and how it's impacting the business, and to be able to communicate, justification of funding levels, and developing business cases to acquire the resources we need. You're right. We've done such a good job operationally that unfortunately I think we've delayed this need to actually get funding and resources to address some of these challenges.
Do you you talk about the operational, and we talked about a little bit in salary. Where are those gaps? What do we need to, how do we support somebody who's coming in maybe without a lot of experience? How do we allow them to run a hospital facility? Do you kind of find it or on this side with people who've been in healthcare facilities management for a long time, 25, 30 years, maybe they didn't need to speak the language of finance when they came up because they could just keep things running. Is that a gap that you found for maybe more experienced people being able to translate the operational into the financial and presenting it to leadership to help with some of these issues?
Yeah, I think generally the industry is struggling with this competency. I don't necessarily think it's a matter of age. It's just kind of some people understand it and some people don't, whether that's because they come from on different, usually I will say those who come from outside of healthcare into healthcare are much more savvy in the communication of communicating the value of facilities to the executive suite. That I will say anecdotally that seems to be the case, because in the corporate world that's what it's all about. I mean, and in the healthcare it is very much operational focused. So that I will say if there is a difference, I notice that seems to be the issue.
So what did your study reveal to you?
Yeah, so in short, what it's showing is that having an adequate level of operational budget for facilities is justified from future savings on capital costs. So what I'm saying is that if we don't spend enough maintaining our facilities, we're going to pay more to do replacements in the future. And so this is helpful for those facility leaders that are struggling, like most are, with this pressure to many times reduce or just keep maintaining their operational budgets, even though regulation and compliance issues are compounding, and maybe even adding a wing to their hospital, right? They're being asked to do more with less. And so this data provides, is it actually provides justification for a facility to say, time out. There's actually an ROI to me having an extra FTE or to having some more money for maintenance, because it's going to save me money down the road in not needing to replace that generator as fast as I may now, or the air handler as quickly as I needed to. So that there's a linear relationship between your operational spending and your capital renewal spending. And unfortunately, a lot of hospitals think the reverse and say, hey, I'm going to save, thinking short term and saying, I'm going to save a few dollars because I'm not spending as much money on facility operations, but it's going to come back to bite. And so being able to articulate that, right, is helpful, I think, to say, well, hey, time out. We can't just keep cutting our budget, because not only is it not helpful for me operationally, but there's a financial impact to this. There's an ROI attached to this decision.
This concludes episode 1. Please return to the Healthcare Facilities Network in the near future to view episode 2. And as always, thank you for watching.